IUI is one of the fertility treatment options we offer here at the center. It's used to improve the odds of conceiving, and today on Lunchtime Live at the Center, Dr. Andrea DiLuigi is here to talk about the ins and outs of IUI. Dr. DiLuigi, welcome back.
Thank you, Ami. So good to see you.
Thank you. It's good to see you too. Can you talk a little bit about what IUI is? What does it stand for?
So IUI stands for intrauterine insemination. Older terminology was artificial insemination, but we tend to use intrauterine insemination now to describe it. And it's a really simple, safe procedure where we insert sperm into the uterus to allow the sperm to get closer to the egg.
How would that be done? How would you insert it?
There's a little bit of a process. I mean, that happens in the lab, but I can show you what the catheter looks like. So we have this really small, flexible catheter
Excellent.
that we insert into the uterus, and it feels kind of like a pap smear. So it's really not a painful procedure. Patients come in, they get undressed from the waist down, cover up with the sheet, and we insert a speculum, which is the instrument that's used for a pap smear to give us a good view of the cervix. And then we gently introduce the catheter into the cervix and into the uterus, and then place the sperm high up in the uterus so that they have less distance to swim. And that's helpful because it really is a numbers game. And when patients have intercourse, they lose millions of sperm in the vagina and cervix. And if you can place those sperm closer to their target, it can really help. But it is a really simple procedure performed in the office. And I'll talk in a few minutes as we get to our other questions about the prep for the sperm and things like that.
And when you mention the target, so is the target the uterus, or where does the egg and sperm fertilize?
So the egg gets released from the ovary, and that's ovulation, and then the tube actually picks the egg up. So we have these finger-like projections on the end of the fallopian tube. I have another prop that I can show. This is a uterus that has a lot of problems, so I'm going to turn it around. But this is a normal fallopian tube here, and as you can see at the end, there are these little finger-like projections called fimbria, and their job is to pick the egg up. So the egg gets released from the ovary, the tube sweeps over, picks that egg up, and propels it toward the uterus. The sperm then swim. I mean, typically with intercourse, they're swimming a greater distance. So from the vagina into the cervix and then into the uterus. And then they actually meet the egg in the fallopian tube.
Okay.
And that's where fertilization happens. And then an embryo forms, and the embryo makes its way back into the uterine cavity, and then implantation occurs. So it's quite the distance for sperm to swim. It's a little bit of a journey, so this just helps them. So I like to joke with my patients and tell them it's like if you have a race and you have more runners in the race, but the race is shorter.
All right. So can you talk a little bit about the procedure? Well, maybe start with, if a patient comes to us as a new patient, is IUI the first step once they've gone through the workup and the process and the testing around it?
That's a great question. For many patients, yes, would be the answer to that. So in order to have success with IUI, you have to have at least one open functioning fallopian tube. And patients have to ovulate to be able to get pregnant with the IUI procedure. But if someone comes to us and they don't ovulate, that's a pretty easy issue to fix. We have medication. 2 of them are oral medications that are pretty easy to take for about 5 days. Clomiphene citrate or Clomid, and letrozole is the other one. And those boost ovulation or make patients that don't ovulate. So IUI can be a really good starting point for many patients. But to be fair, I would say that there are other things that go into that decision. For example, the age of the patient, the diagnosis, and it's a discussion that the patient can have with the physician, but the preference is to help patients conceive as easily as possible. And IUI is pretty minimally invasive, so it is a nice starting point for most patients. But of course, if somebody comes to us and they have a history that would make us lean away from IUI, for example, they've had their tubes tied, then IUI would not be a good option for that patient.
And how do you know, would you have to do, say, like an HSG to know that the fallopian tubes are open?
Yes, so there are a few different ways to know that fallopian tubes are open. A hysterosalpingogram or an x-ray that can be done in our office is one way. Some patients come to us and they've had a surgery with, for example, like their OB/GYN or a minimally invasive GYN surgery. So laparoscopy, when a camera is placed into the pelvis, is another way to determine whether or not tubes are open, and dye can be injected into the tubes at that time. So some patients have had that, for another reason. Maybe they have painful periods and their doctor's looking for endometriosis. And if they've had documentation that their tubes are open at surgery, then we don't necessarily need to repeat that HSG test. But those are two ways that you can check tubes. And there is another way. There's a special ultrasound with saline that uses bubbles called a hycosi that some of the minimally invasive surgeons can do too.
And do we do that? Do we do that at our office?
It's not our first choice, just because the imaging with the HSG is more sensitive and you can see the anatomy and take pictures and really get a good idea with the HSG about the shape and size of the uterus. You can also just see the anatomy of the tubes. For example, when we do the x-ray, we want to see the tubes are really narrow. They're pretty skinny. But if we see with this x-ray a dilated fallopian tube, then that can be a sign of a problem too. So to just go back to answer your question, I would say, it's a study that can be done, but we prefer the HSG because we think it's a bit more sensitive in terms of being able to pick up problems with the tubes.
Got it. And so once a patient has gone through their initial testing, what would the procedure look like, or what would the process be like for what would the next step be?
So typically we meet with the patient for the first visit, talk about the testing, review all the results, and then discuss options for a plan. And so at the follow-up visit, we take everything into consideration: the age of the patient, the diagnosis, the results of the testing, the patient's insurance coverage, and really how aggressive the patient wants to be. And one of the important tests is the tests that we do, or I should say tests plural, are the egg supply tests, because those can influence us as well in terms of how aggressive we may want to be with treatment from the beginning. But say we have a patient whose workup is really reassuring, who hasn't done treatment anyplace else before, and is a young, healthy person, then I think IUI is a really nice starting point. Because the cycles are pretty easy and they don't involve a lot of appointments in the office. So typically for an IUI cycle, and I just want to explain this. Sometimes the patients come to us with different diagnoses and they're seeking care for different reasons. Say, for example, we have a single woman who's coming to us for treatment who's never tried to get pregnant. Then that patient may want to use donor sperm to get pregnant with IUI. And if she has regular periods, she doesn't necessarily need any medication to boost her ovulation. So that would be a very simple type of cycle, which we call a natural cycle IUI, where the patient would just call on day 1 of bleeding, which is the first day of bright red flow, and then would start testing with an ovulation predictor kit to pick up her ovulation around cycle day 10. And then when she gets her positive, we schedule the IUI, and we have patients test in the afternoon or early evening. And when they get their positives, we do the insemination the next morning. So that patient in that scenario would only need one visit, and that's for the actual IUI. For patients who don't ovulate on their own and need ovulation boosting or ovulation induction medication, or if that's recommended by someone's physician to increase the chances of pregnancy, there's typically another visit around cycle day 10 for an ultrasound, just to see how the medicine's working, make sure the response is safe. For example, we don't want too many eggs to be ovulated, and the risk of multiple pregnancy is pretty low with medications like Clomid or Letrozole. It's about 5 to 9%. But we would like to do an ultrasound just to make sure the lining of the uterus looks good and we have an appropriate safe number of follicles. And then that patient starts testing and then would come in for the IUI. So in that situation, it would be 2 visits during the cycle. So it's still not bad.
And so is it typically, you said Clomid and Letrozole, those are pills. Do we also use injectables for some patients?
We do. It depends on the patient's diagnosis. Some patients who don't ovulate need, based on their hormone levels, injectable medication instead. But if they need that, the needles are very small and they're very patient friendly. It's very easy to teach the patient how to do that. But most patients that proceed forward with these types of cycles would start with oral ovulation induction medication.
Okay. And so can you talk a little bit about the procedure itself and what to expect from someone can expect from it?
The procedure is honestly really, really easy. It's a low risk procedure. The risk of a complication is less than 1%. And complications could be things like infection, but infection, the risk is so low. It's actually, I can't give you an actual number, but way less than 1% because the way the sperm is handled in the lab, the conditions are sterile. And the catheter is sterile when we insert the sperm into the uterus. So really for preparation leading up to the day, we just need to help the patient pick up ovulation. And that can be done with the home ovulation predictor kits and patients that have success with those. Some patients will have a hard time picking up a positive, and we oftentimes know that from their history before they do their cycle.
Oh.
And those patients would be good candidates for blood work to pick up the ovulation. So usually around cycle day 10 or so, we'll start doing daily blood work to pick up the ovulation to time the insemination. And some patients are taking a trigger shot, which is a medication to help the patient ovulate. So that's another option too. But before the patient comes in, we would need to wash the sperm sample if it's a partner sample. So the lab would have a partner drop off the sample at around 8 o'clock in the morning. The andrology lab, then prepares it for insemination. So they wash it, they remove any substances that should not go into the body, for example, any skin cells or dead sperm, things like that. And they spin it and remove all the slow or non-moving sperm. And then they're left with the fast swimming sperm, and those are what we use for the insemination. If someone is using a donor sperm sample, those arrive frozen and they stay in our lab until the patient ovulates, and then that gets thawed the day of the insemination, so right before the patient comes in.
Okay.
So for the person having the insemination, there's really no preparation. It would be like if someone went to their OB for a pap smear. You just come in advance. There's an electronic consent form that we have the patient sign, but we place a speculum like we do for the pap smear, visualize the cervix, and then gently place the sperm into the uterus with this little catheter. And it's in a very small volume of fluid, so it's not a painful procedure. It's just a small amount of fluid that goes in. So once we deposit the sperm into the uterus, we remove the speculum and the catheter, and we have the patient rest for about 10 to 15 minutes just to give the sperm a little bit of time to swim toward the egg.
And does someone's bladder need to be full for this?
No. So we actually have patients empty their bladder before, just to
Oh,
make it
okay.
a little more comfortable when they have the speculum exam. The one situation where we would want a full bladder would be if someone needs to have an abdominal ultrasound to have their procedure performed, but that's not typical.
So, and this procedure is not done under ultrasound guidance?
No, it's a very easy procedure. It does not require ultrasound, but in certain situations, patients can have a little bit of a different curve to the cervix or uterus, or for example, someone that's had multiple pelvic surgeries or multiple C-sections, if they have a little bit of scar tissue at the junction of the cervix and the uterus, at the lower part of the uterus, sometimes it can be a little trickier to guide the catheter in. So in those situations, we use the ultrasound to help us, but that's very unusual. It's very simple. It usually takes, well, the appointment, I would say, to expect to be there for 5 minutes to change, and then someone would come in and review the sample and explain the results of the semen analysis that's performed on the sample, and then do the actual procedure. And then there's the resting period after, but the catheter is in for less than a minute. It's really fast.
And do they need to spend the day resting? Can they get up and move? What kind of activities can they be involved in?
They can go back to their normal activities right after. So patients often come in for the insemination and go back to work. So it's pretty quick and easy, and there are no restrictions after in terms of working. Patients don't have to stay in bed after. But we always tell patients to assume that they're pregnant after their procedure. So we want them to be mindful of, what they're eating and drinking. For example, we would not recommend that someone have a glass of wine right after their insemination because we don't recommend drinking in pregnancy. But other than those restrictions, there would be none. And we tell patients that if they feel up to it, if this is someone using partner sperm, for example, they can have intercourse the night of the insemination if they want to just try to increase their chances, but they don't need to if we have an excellent sample.
And are there any post medications, post IUI medications like, say, progesterone that we recommend?
That's dependent on patient diagnosis and the history. But if someone ovulates on their own and their hormone levels are normal, progesterone is typically not required. But in certain situations, it can be recommended. For example, in patients that have a history of a low progesterone, especially if we've picked that up in our monitoring, or someone that has recurrent miscarriages, some patients are using progesterone, but in most situations, no, it's not required because the patient is ovulating and making progesterone in that cycle.
Got it. And for patients who come and do more than one IUI, how do you determine how many IUIs a patient would do?
That's a great question. It really depends on the patient's age, the diagnosis, someone's level of frustration. For example, sometimes I'll see a patient that's been trying to conceive for 3 years before they see me, and they're over 35 and they're anxious about the biological clock ticking. Sometimes those patients don't want to do very many IUIs, but typically up to 3 is pretty standard because most pregnancies occur in those first 3 cycles. But there are situations where we would potentially recommend more. For example, going back to the case where we talked about a single person or a same-sex couple using donor sperm and there's no diagnosis of infertility, you can be a little bit more flexible with the number of IUIs that you do. But it is pretty standard for some insurance companies that cover infertility to cover 3 inseminations and 2 IVF cycles. And I mean, that's not everybody's plan, but that's a common coverage that we see.
Yeah.
So that plays into it too. If someone has 3 covered IUIs, many patients want to use that coverage. And then if they're not successful, we'll discuss IVF as a next step.
A lot of factors, a lot of personalization here. You touched upon the risk. Any risks associated with this, or anything that you'd like to mention on that?
The risks are really small. The risk of infection, as I mentioned, is less than 1%. And if I had to say that if a patient were to complain about something on the day of, it's just that most patients don't enjoy a speculum exam for a pap smear. So the same thing holds true of this, that it's a little bit of pressure to have a speculum placed in the vagina. So that's one thing. And then just a little bit of cramping as the catheter goes in, but again, very comparable to a pap smear. And sometimes patients have a little bit of spotting from the catheter being inserted, even though it's tiny. I mean, it is very, very small. But sometimes patients can spot after a pap smear as well. So this would be very similar. So those are the biggest risks. If someone takes ovulation induction medication, we would counsel them about the risk of multiple pregnancy. And with those oral medications, the Clomid or letrozole, it's pretty low. The risk of multiple pregnancy is about 5 to 9%.
Oh, okay.
So it's not a high risk, but it can happen. So that's why that ultrasound is important to see what the response is like, because it's a very individualized treatment plan. We want to make sure the patient is having success, but we want to make sure that we don't put people at increased risk. And we definitely don't want to create any triplets because they are high risk pregnancies and can deliver prematurely. So yes, so that's another risk if there's medication taken.
Got it. Dr. DiLuigi, thank you so much for coming today and sharing. This is really helpful. And I know a lot of people will benefit from this.
Well, thank you for having me. Enjoy the rest of your day, and thank you to all the listeners.
Yeah. And thank you for being here. And we'll see you next time on Lunchtime Live at the Center. If you'd like to learn more about how we can support you, please do check out our website at yukonfertility.com. Take care.
Take care. Bye-bye.